We described the HIV life cycle and the mechanism of action of antiretroviral agents, and given a treatment-naive HIV patient, we recommended DHHS guideline concordant antiretroviral therapy. And when indicated, we recommended immunization to patients living with HIV. Now, given an HIV patient, let's design an individualized monitoring plan. First, let's take a look at a few definitions. Viral suppression by definition is a HIV RNA level that is below the lower limit of detection of available assays. In clinical trial, usually this is considered a viral load less than 50 copies per ml. Virologic failure is any time the viral load is actually more than 200 copies per ml. Incomplete virologic response if the viral load is greater than 200 in two consecutive viral loads that are separated by 24 weeks. So if you get a single level that's greater than 200, it doesn't necessarily mean that it's a complete virologic response. You have to look at the trend. So it could be that the viral load is greater than 200, but it's trending down. So it's important to get a second one and to see if it's trending down or up. Virologic rebound is when a patient has virologic suppression, but then after virologic suppression, then the viral load becomes greater than 200 copies per ml. And a virologic blip is once the patient gets virologic suppression, then there's a single isolated detectable RNA level, and then the patient goes back to suppression. So this is a quick virologic blip. And of course, low-level viremia is if the virus is actually detected, so greater than 50, but actually less than 200. Let's take a look at what happens when we actually initiate ART. In an uninfected person who does not have HIV, a normal CD4 count is usually around 800 to 1200 cells per microliter or more. In HIV-infected patients, the CD4 count starts to drop. So for most patients, about 200 to 500. And of course, once CD4 count drops to less than 200, at that point, the patient has AIDS. Alternatively, if the percentage of lymphocytes that CD4 is 14% or less, that also constitutes AIDS. Now, once we initiate ART in the first month, so within 30 days, you should suspect a 2-log drop in viral load. So, for example, if, and of course, every log is you basically drop a 0. So if the viral load is 100,000, a 2-log drop would be you just take out 2 zeros out, so it would be 1,000. So you would expect the patient to go from 100,000 to 1,000 within the first month. And then 3 to 6 months, you should have undetectable viral load because the ARTs that we currently have on the market are highly effective. Now, when it comes to CD4, within the first year, it's expected that the patients will gain about 150 to 250 CD4 cells, and this levels off beyond 2 years, so this will not continue to go up to normal. So the goals of therapy is to have an undetectable viral load and to have CD4 count of at least 500. And that's because typically less than 500 is when opportunistic infections start to emerge, especially if it's less than 200. Let's take a look at monitoring parameters for HIV. So you can see, so green means that you basically need to get this laboratory parameter for everyone. And yellow means that for some patients, you also may need to do that. So at baseline, before we actually start ART, we need to check a viral load, CD4 count. We also need to check HIV resistance to make sure the regimens that we choose initially are actually working, because there's a possibility that the patient can get a resistant strain from somebody else. It's important to check for hepatitis B serology and for hepatitis C. Risk factors for getting HIV are similar to risk factors for getting Hep B and Hep C, so it's important to get these and treat these at the same time as HIV. Urinalysis is important for monitoring the renal function. So for example, you can measure the urine protein as well as urine glucose, which normally should not be in the urine, but people who have renal dysfunction will have glucose and potentially protein in the urine. So that's an easy way of monitoring renal function. And then for more comprehensive monitoring, a basic metabolic panel as well as liver chemistries and complete blood cell count are needed at baseline. And because HIV patients are at risk of cardiovascular disease, it's important to get a baseline fasting lipid panel and a fasting glucose or A1C so that if these are abnormal, they get the appropriate treatment. And if you are to use abacavir, you need to get the HLA-B 5701. If you are not using abacavir, this is unneeded. And tropism test is only needed if the patient is to be started on Maraviroc. So if the Maraviroc is not needed, this test is unnecessary. And then 2 to 8 weeks after ART is initiated, it's important to get the HIV viral load. Now, if the patient's viral load is undetectable 2 to 8 weeks, then you can monitor it every 3 to 4 months. However, if the viral load is not undetectable 2 to 8 weeks, it's important to continue to monitor the viral load more frequently, so every 4 to 8 weeks until it's undetectable or at least is less than 200 copies per ml, and then you can switch to every 3 to 6 months. Now, for patients who actually have good adherence and they have suppressed viral load, you can actually make this easier and do it every 6 months. But that's only if the patient is adherent and the viral load at this point it was suppressed. So at the very least, the viral load needs to be monitored every 6 weeks. And if the patient's treatment fails, it's also important to check the viral load, and in fact, that's how you would know if the treatment is failing. And of course, situations were clinically indicated. For the CD4 count, once you start ART, it takes about 3 months for the CD4 cells to increase, so it's unnecessary to get one 2 to 8 weeks later. So typically, it's recommended to wait 3 to 6 months to get the CD4. And this is only needed if the patient's CD4 count was low or if the viral load is undetectable. Otherwise, if the CD4 count was already high, so greater than 300, and if the viral load is undetectable at 2 to 8 weeks, it's unnecessary to continue to monitor CD4 count because there will be no reason for the CD4 count to go any lower. Now, beyond 2 years, if the patient's CD4 count is still low, if the viral load is suppressed and they are adherent, you can actually make that easier and do it every 12 years or annually. And of course, anytime treatment fails, you should check viral load as well as the CD4 count, and if as clinically indicated. So clinically indicated, it just depends on the situation. You have to use your judgment because we couldn't possibly, or I should say, the guideline couldn't include every possible scenario. They just have the things that you should check as clinically indicated based on clinical judgment. HIV resistance is needed at baseline, but then you don't really need to do it unless the patient has treatment failure or you have some reason to believe that there is resistance. Otherwise, it's not really needed. The same with Hep B and Hep C, you definitely need it at baseline. If someone is at risk of getting Hep B or Hep C, or especially with Hep B, if they're unvaccinated, it's good to check these annually. Urinalysis that you need at baseline for renal function monitoring, you really need to get that every 6 months if someone is on tenofovir, so either TDF or TAF, because these are nephrotoxic. It's important to get urinalysis every 6 months. Otherwise, if someone is not on tenofovir, then you need urinalysis once a year or every 12 months, and if clinically indicated. For BMP and liver chemistries, you do get them at baseline and then 2 to 8 weeks just to make sure that the patient is tolerating the drugs, and then every 3 to 6 months just to make sure the drugs are not causing any toxicity. With the complete blood count, you do it at baseline, and then anytime that you need to get the CD4 count you know, for example, if you do need the CD4 count every 3 to 4 months, you also get the CBC. But at the very least, it's also recommended to get it every 6 months, and if clinically indicated. For the fasting lipid panel and glucose and A1C, you only need it annually, so at baseline, and then every 12 months, unless it's if they were abnormal at baseline. So if someone's lipid panels was abnormal, you should do it twice a year. And the same with A1C. If A1C was abnormal or glucose, you should do it every 3 months. HLA-B 57, you really don't need to repeat it once you get it at baseline. And that's only if you need abacavir. So if abacavir is not in the picture, you never need the HLA-B 5701. Tropisome, you only need it if someone is on Maraviroc. If the Maraviroc is not in the picture, you never need it. So if you are to use Maraviroc, you need it at baseline. And then if the patient has treatment failure, you need to recheck tropisome, and if clinically needed. You can use Maraviroc if the tropisome test shows CCR5, not CXCR4.